Welcome to this edition of ECG 5-Minute Consult, brought to you by myself, Bill Hayden, co-author of ECG for First Responders, available at Amazon.com. ECG 5-Minute Consult series highlight 10 potentially lethal ECG diagnoses that may go unrecognized. So far we have discussed Wellen syndrome, digoxin toxicity, pulseless ventricular tachycardia, cardiac tamponade, long QT syndrome, and today's case. Paramedics respond to a call for a 36-year-old auto mechanic experiencing chest pain at work. He says his pain began as he was removing a battery. His pain is in the center of his chest and still present. He describes his pain as tightness. He feels short of breath. Any exertion seems to aggravate the pain. Pain is non-radiating. He rates his pain as 6 on a 10-point scale, with 10 being the worst he has ever experienced. He has a 6-year pack history of cigarette smoking. He denies any drug use. Alcohol consumption is 12 or so beers on weekends. Past medical history includes hypertension for 4 years and high cholesterol for the same period of time. Current medications include lisinopril 40 mg daily and atorvastatin 40 mg at night. On physical examination, he is awake and oriented ×3. Blood pressure is 160/90. Heart rate is 68. Respirations 18. Pulse oximetry 93%, temperature at 98 degrees Fahrenheit. His chest is clear to auscultation. His heart has a regular rhythm with no murmurs or extra sounds. Paramedics obtain the following 12-lead ECG. Test your knowledge. Given this patient's symptoms, history, and physical examination, what is your ECG interpretation? A. Hyperkalemia. B. Normal ECG. C. J-point ST elevation. D. Bundle branch block. E. Occlusion myocardial infarction. The correct answer is E, occlusion myocardial infarction. Let's first analyze this ECG using the primary survey. The ECG primary survey is a method to quickly identify potentially life-threatening emergencies on ECG. The primary survey answers these 4 questions. Number 1, rate. Cardiac emergencies involving rate. Is the heart rate too fast, tachycardia, or too slow, bradycardia, causing signs of cardiac instability such as chest pain, altered mental status, shortness of breath, shock, hypotension, or heart failure? He has no signs of cardiac instability. You can quickly estimate most heart rates by applying the 300, 150, 100, 75, 60, 50 sequence rule. On the rhythm strip, start where a QRS lands on a small box grid line. If the next QRS lands on the next small box grid line, the rate is 300 beats per minute. Or, should the next QRS from the starting point land on the second small box grid line, the rate is 150 beats per minute. In the example below, the rate is 60 beats per minute. You can also estimate rate by counting the number of QRS complexes that occur during a 6-second time period, 30 large boxes, and multiplying by 10. Our patient's heart rate is approximately 68 beats per minute. He shows no signs of cardiac instability, such as chest pain, altered mental status, shortness of breath, shock, heart failure, or hypotension due to heart rate. Number 2, rhythm. Cardiac emergencies involving rhythm. Is the rhythm supraventricular or ventricular in origin? The QRS is narrow, that is, less than or equal to 3 small boxes. Therefore, this is a supraventricular rhythm. These rhythms tend to be stable unless prolonged for an extended time. In this ECG, QRS intervals are narrow, as defined by a width less than 3 small boxes. If QRS intervals are less than 3 small boxes, the rhythm is presumed supraventricular in origin. If the QRS interval is greater than 3 small boxes, with no associated or discernible P waves, consider the rhythm ventricular in the setting of acute chest pain. Number 3, ST segment. Cardiac emergencies involving ST segments. Are ST segments consistent with ST elevation myocardial infarction, STEMI, or non-ST elevation myocardial infarction, non-STEMI, or other findings of occlusive myocardial infarction present? Yes, findings of occlusive myocardial infarction are present in this ECG. Traditional benchmarks for myocardial infarction. STEMI, elevation of ST segment in 2 contiguous leads above the baseline, and NSTEMI, ST segment depression and/or T-wave inversions with elevated troponin, have been diagnostic paradigms for myocardial infarction for over 20 years. Recent research has demonstrated that these criteria, as sole benchmarks of myocardial infarction, may delay or overlook reperfusion therapies in as many as 25 to 30% of occlusive myocardial infarctions among STEMI patients. Beyond STEMI and NSTEMI, a different diagnostic paradigm: occlusive and non-occlusive myocardial infarction. Occlusive myocardial infarction. There is insufficient collateral circulation to prevent total occlusion. ST segments may or may not be elevated. Troponin is elevated. Other signs of occlusive myocardial infarction may be present, for example, De Winter sign. ECG may be normal initially. Urgent reperfusion therapy is needed. Non-occlusive myocardial infarction. Sufficient collateral circulation is present to prevent total occlusion. ST segment depression and T-wave inversion may be variable. Troponin is elevated. Diagnostic angiography usually required within a few hours or day of onset. De Winter sign characteristics, a special case of occlusive myocardial infarction. Upsloping ST segments are present in usually 2 or more leads. Limb leads 2, 3 AVF, and chest leads V2 to V6. Purple arrows. ST segment depression and T-wave height are often maximal in V3. 1 to 2 millimeter ST segment elevation in AVR may be present, red arrows. Relatively tall, symmetric T-waves with possible loss of precordial R-wave progression may be present. Significance of poor R-wave progression in chest leads, association with adverse prognosis in the general population, and sudden cardiac death in subjects with coronary artery disease. Normal R-wave progression in chest leads is demonstrated by the red arrows. Poor R-wave progression in chest leads is shown by the purple arrows. T-waves. Cardiac emergencies involving T-waves. When present, are T-waves consistent with occlusive myocardial infarction? Yes, De Winter T-waves present. Other findings of occlusive myocardial infarction: De Winter T-waves. De Winter T wave characteristics. Relatively tall, symmetric T waves, red arrows, somewhat fat at the base, with possible loss of precordial R wave progression. Note, T waves in hyperkalemia tend to be peaked and narrow-based. Other findings of occlusive myocardial infarction, De Winter sign. De Winter T waves, referred to as De Winter sign, have been associated with occlusion of the proximal left anterior descending coronary artery, commonly referred to as the widowmaker. Dr. Robert Jan de Winter is a Dutch professor of cardiology with a special interest in acute coronary syndromes, with over 20 years of involvement in clinical trials. First reported by Dr. de Winter sign indicates a proximal left anterior descending coronary artery occlusion. Implications for care. Follow local protocols for assessment, treatment, and transport. Obtain focused history and physical examination. Recall that occlusive myocardial infarction may present with atypical chest pain, especially among elderly patients, women, and diabetics. Obtain on-scene 12-lead ECG and transmit to medical control. Depending on training and experience, look for ECG findings of occlusive myocardial infarction, such as STEMI, NSTEMI, and other atypical findings of myocardial infarction, such as De Winter sign. Remember that an initial ECG may appear normal. This case featured a 36-year-old male with chest pain. His ECG was abnormal, with presence of De Winter sign, indicating proximal left anterior descending coronary artery occlusion. Thanks for watching ECG 5-Minute Consult, and we hope you'll take a look at our book, ECG for First Responders, available on Amazon, The Perfect Introduction to ECG Interpretation.